Okay, so our second lunch talk is going to be by Dr. Bongmba. He's the president of the African Association for the Study of Religion and is managing editor of the Religious Studies Review, in addition to his work as professor of religious studies at Rice University. His interest in global health involves faith-based organizations in Africa and the Ecumenical Pharmaceutical Network, which he will be discussing now.
Thank you. Thank you so much. Thank you for inviting me to, I would consider this as sort of promotion, but I think you will see the context in which this promotion takes place. And rather than give you a lengthy background, let me just walk through this. I was aware of the Ecumenical Pharmaceutical Network and other Christian health organizations in Africa when I was writing a book on the church and HIV/AIDS in Africa. In the interest of full disclosure, as I say, I have since become an affiliate member of EPN. I should also let you know that when we get to the fancy slides, they are their slides. I have permission to show them to you. I have used them at other presentations before. My interest in the material is threefold. One, continue to survey what religious communities do through their healthcare system when faced with a pandemic. The broader questions here involve responsibility at the individual and corporate level, corporate here meaning the religious community. And this is part of an ongoing investigation that I'm interested in reassessing, at least grounded in largely philosophical terms, what global responsibility at a time of crisis like this would look like. Then number two, the interface between what religious communities do and public policy on healthcare. And then chart out new possibilities between religious communities and other stakeholders in healthcare, mainly researchers at different levels. Here is the context, of course, HIV/AIDS, and it has all the statistics that you're familiar with. I think you all know very well the impact on healthcare systems in Africa. You know the work of UNAIDS. I don't need to bore you with that. And fighting that pandemic has, in Africa particularly, involved church groups. A very well publicized study that was done in Southern Africa for several years indicated actually that when you look at Africa from an asset-based analysis, religious communities sometimes contribute between 20 and 80% of the healthcare system. So we're really talking at a very, very large involvement. And my focus has then been with groups like the Christian Health Association of Africa. I grew up in Cameroon, so I'm very familiar with the health work of the Cameroon Baptist Health Board. The state was late in launching its assault on HIV/AIDS, as we know in Africa, and I don't need to bore you with that information. And then there are other global partners that have worked to try to fight HIV/AIDS in Africa. But I think, as all of you know, the greatest challenge in this battle has been the access to medicines. Early treatment cocktails only very few could afford. In Africa, healthcare systems were not able to address it adequately. It took very bold action by Treatment Action Campaign in South Africa to be able to promote access to health care. But as that started, you know, the global response with the initial 3x5, that is 3 million on antiretroviral by the year 2005, failed. And so the revised plan by the World Health Organization and UNAIDS was to return to primary health care as a large part of fighting these kinds of difficult problems, meaning we were not going to look at this as some sort of specialty, but allow doctors and healthcare professionals do what they do best, which is focus on the total healthcare system with an emphasis on primary health care. Today, 5 million people have access to drugs. That's great strides, but in the light of the magnitude of the infection, this is just a very small figure. Now, EPN, my interest in EPN, and this is really where it's crucial. 1997, World Health Organization published a revolutionary list of essential medicines. And this is from a study that was first published in 2003. It was a complex and challenging undertaking. Defining EML has continuously shifted more and more, guided by evidence-based research, always understood in terms of relevance to public health and other criteria which have included efficacy, safety, and cost of the medicines. Changes over the years now consider antiretroviral prescription issues, rational use of medicines, drug effectiveness, morbidity rates and patterns, and that helps the World Health Organization determine what to include on that list regularly. 2001, the model list was issued, challenged, revised, largely challenged by the United States actually, revised and then eventually adopted by the World Health Organization executive in 2002. And there is the website where you can actually find this list. The final document considered, before they put the final document up, they actually considered the political battle that took place in the World Trade Organization, the Treaties of Intellectual Properties and Rights Agreement, which covers all people regardless, which argues that when research and development of drugs have taken place, the benefits should cover all people regardless of whether they have the capacity to produce the medicines locally. And so the challenges then, and especially for Africa, remained the supply of essential drugs. Since those debates at the World Trade Organizations, there have been developments in India, Brazil, in many parts of Africa, cost of shipment and transportation, or the effect of transportation, as previous studies have shown that when drugs are transported to Africa, in some cases, by the time they arrive, they have lost significant medicinal components. So these things are all things that continue to challenge the availability of essential medicines in Africa. But then, of course, you have things that have been alluded to in different ways at this conference, problems with custom clearance, largely due to political corruption. Then you have this leading to pharmacies, pharmaceutical practices in Africa, many of them largely private businesses. They are issued licenses to import and sell drugs by the state. In some cases, they actually can do so without paying custom duties, but clearing them is usually a huge problem. Then you also have state-controlled pharmaceutical practices, which poses challenges. They can impose state controls, bureaucratic practices that hinder the process, taxation issues, and so forth. It is in this context that faith-based organizations became a major partner in the provision of essential drugs. And 30 years ago, the Ecumenical Pharmaceutical Network then was formed. It's a network. It's a Christian organization, not-for-profit, independent, committed to the provision of quality pharmaceutical services as a means of achieving global goals and targets on healthcare and access to medicines. It's a worldwide network. Members join as associations, institutions, and then you have individuals who can become members of it who have an interest in what is going on. The main goal really is to ensure the delivery of just and compassionate quality pharmaceutical services, and this is language from the EPN website and from the brochure, and that is crucial. The term just here goes to the kind of language that is often employed by religious communities when they talk about trying to access and provide assistance to underprivileged people globally. And then, of course, compassion being a key ingredient of the kind of work that they do. So the origin, 1981, the Christian Medical Commission of the World Council of Churches recommended a consultation, and you can see the fancy graph there that tells you that this is one of theirs. A pharmaceutical area to the church, particularly in Africa. And so the commission selected a pharmaceutical advisor to study and address and access it. And then 1997, church-based organizations supported by the advisor formed the Ecumenical Pharmaceutical Network. registered as a non-governmental organization in Kenya. This is their slide again. They work with church health systems, and they play a key role in healthcare in Africa. Up to about 40% of the health services in the rural areas, as they estimate, are provided by members of EPN. And then what do? They coordinate, work with healthcare systems to ensure efficient and effective pharmaceutical services. This is their slide. I've modified the language a little bit to suit what I want to say this morning. And then they provide access to affordable and quality medicines for those organizations. And EPN has a vision to serve as a global partner that promotes just and compassionate service to all. And it considers its mission in supporting church and all healthcare systems with quality, as its mission, supporting all healthcare with quality pharmaceutical services. The values are integrity, compassion, respect for others, conscientiousness, continuous learning, professionalism, fairness. And they focus on governance, and their governance system has a general meeting, which is the highest decision-making organ of the group. I have attended only one of those big meetings. It's constituted every 2 years, open to all members of the network. And the EPN board then plans and carries out policy, strategic direction, and members of the board are drawn from different categories of membership, and they are eligible to serve for up to 6 years. This is what its organizational chart would look like. You can access this online actually quite easily, and so I don't need to go over that. And then the programs they have, and this is, again, their own slide. They want to promote access to medicines, but they emphasize rational use of medicine. And this is work very carefully with physicians and with the advice of medical personnel to be sure that the drugs that are prescribed are the ones that the patients need, that will take care of the issues rather than I remember when I grew up in Cameroon, you get ill, you go to the doctor prescribes a long list of drugs. Even if they admit you into the hospital, then you go out to the pharmacy in the city, buy all of those drugs and bring. And sometimes it turned out you probably didn't need all of that. And so the term here, rational here, I think many of you are probably much more familiar with that than I am. Because it says a lot to the practice of medicine today. And of course, they focus on HIV treatment, but I think they have a very big role in professionalizing pharmaceutical services. That doesn't mean that they actually provide the training, but they make sure that the pharmacists at the church-related institutions continue to keep up their practice and work with all professionalism that one can expect. And then, of course, they share pharmaceutical information. And then here again is this business of access to rational use of medicines that is very big with EPN. So it is an objective. How do they seek to meet those objectives? And this is directly from their work. Explore and propagate access to and rational use of medicines. Develop and support improved medicine supply organizations, and there are several of those organizations within the member associations in different African countries today, and church health institutions. And then they promote collaboration between church and state and medicine supply organizations, develop and disseminate tools for managing medicines, raise awareness on medicinal use, and then develop and support quality assurance of medicines. This last one is actually new to them, and it is very at the last general meeting it was very interesting, and I may get to this, but I might as well tell you this story here. They are now beginning to monitor the drugs that they order from overseas, and they told a story that they have set up labs where they actually test the medicines to see the pharmaceutical components, all of the things that the producers claim have gone into producing the medicines. And when they tested a whole batch of a shipment that they had received, it failed woefully. And then when they contacted the manufacturer, rather than say, oh, we are sorry that happened, the first person, first of all, just gasped and said, oh, that was not meant for you. And then the question then is, who was that meant for? Who was that meant for? And I think this is a very interesting development in their work. If they are able to determine that this is the case and are going ahead and testing almost every product that they receive, I think they are on the road to dealing with fake products. This is significant. And significant not only because of the issue of fake drugs that are awash in the market in different African countries, it is also significant because it opens, I think, a window, like I would say, and this is where my whole interest in this is driving to, further research and collaboration, not only with universities and institutions and producers of medicines, but even with people engaged in global health, the ability to be able to test those drugs and assure that the quality is what the manufacturer claims it is, I think talks or gives us an indication that there is a possibility in which medical institutions that are run by these type of religious organizations can begin to combine and bring together palliative care with active ongoing research with institutions that are engaged in these on these questions. And so then they are interested in professionalizing services. How will they do this? Identify, develop, promote acceptable standards of service, carry capacity building and skills development, mentor, develop, and use member expertise, and sensitize church health systems on the idea of professionalism. I think the temptation with religious groups like this is when you start to talk with them, they talk more about their faith. And if you belong to the Christian tradition like I do, we first all, talk about our faith and loyalty to Jesus and all of that. But I think the idea here is that, sure, you may be a person of faith, but you are also a professional. You are also a professional, and that profession requires a different set of skills and standards. And our time is running out, and let me wind this. And so they share information. We have talked about this. There's no need to go into details. And then they have important tasks to promote standards, strengthen capacity, conduct operational research. And I think this is very important. This is new. This is something that I think many of you can actually become interested in what they do and help actually shape that kind of research in the near future, promote networking, and then represent ecclesial communities. Here is the membership throughout Africa. They also have some internationally. It's a global network. And then here is where they are supplying drugs: Ghana, Tanzania, Uganda, Zambia, Cameroon, the Democratic Republic of the Congo, Kenya, Malawi, South Africa, and Rwanda. And then, of course, they acquire essential drugs, but what they do is they follow discount rates recommended by WHO, UNAIDS, UNICEF, and the UN Population Fund. There is more to that will be, and so they have different credit terms and conditions, but they face challenges with delivery times, and then they have donations, which sometimes depress sales. Some medicines are wasted when they arrive, but they are working to make sure that they can correct that. I think my time is up, but this is where the crux of this comes for me. What is the relationship with the African state, which in many cases does very little, but holds a lot of power? That relationship is unavoidable. It's not always been cordial because of the bureaucratic system, which is often slow, waste in state systems. But sometimes we need to know that the state also has very legitimate concerns in terms of quality and so forth. And sometimes the state has the right questions when it comes to how rational have the medicines and the things that have been donated from overseas been used. They need each other in order to be able to work effectively. This is not going to be an easy road for the ecumenical pharmaceutical network, but this is a road that they must take. This is something that I'm interested in exploring, the challenges facing this model. Of course, it's also always going to be the religious question. And the third one for me, and I am really concerned about this, is there seems to be no clear connection to academic institutions. And a lot of the research that EPN could benefit from is done without any direct connection to them, and this is something that one can do. I'm interested in writing, and I manage a journal, and I have been trying for the last year to work with EPN to actually start a journal where they can report and talk about their own research and collaborate. They want to do that, but when I contact either the social scientists or people in medicine, they don't want to touch it because that's a religion. So if there's any of you that is interested in that, please, I want to talk with you. I think there's important work going on in EPN that needs dissemination in a forum that will be scientifically acceptable to people in your field who can contribute. Then, of course, sustainability remains a crucial issue. It offers hope. I hope that EPN continues to succeed, but these challenges, I think, are some things that need to be addressed if EPN is going to continue to provide the kind of access to rational medicines that they have set out to do. Our time is up, and thank you so much.